practitioner, we feel like this pharmacology course is the right course for you. So I hope you enjoy this lecture, and I know that it's going to help you learn more, save time, and be awesome.
Hi, I'm Dr. Michael McInnes. I'm an internist, and this lecture is on drugs used to treat heart failure. Now, when we talk about congestive heart failure, we're talking about a syndrome of pump failure. The heart is a pump, and if it's no longer able to pump blood, then you have heart failure, you have congestive heart failure. It's not really a primary disease in and of itself. It's more accurate to talk about the diseases that cause heart failure. One of the most common of these diseases is cardiomyopathy, and the most common type of cardiomyopathy is ischemic cardiomyopathy, where you have atherosclerotic disease or myocardial infarction, and that ischemic disease leads to damage to the heart muscle. We treat a lot of patients for atherosclerotic disease. We treat a lot of patients with angina. We treat a lot of patients with MIs, and we improve survival so those patients survive and go on to have cardiomyopathy due to their ischemic disease. Other diseases can cause cardiomyopathy, however. Viral myocarditis, or an infection of the heart muscle, can cause cardiomyopathy down the road. You can have valvular heart disease, such as aortic stenosis, that can lead to congestive heart failure. You can also have hypertensive heart disease, where the blood pressure is elevated, the left ventricle has to work harder to pump the blood against that increased afterload, and as such, the heart muscle gets thicker, the muscles become hypertrophied and stiff, and so you have heart failure based on that, which we'll talk about in just a moment. We can talk about heart failure in terms of left ventricular failure or right ventricular failure. Most patients, if they have left ventricular failure, they will develop right ventricular failure. But both of these types of heart failure have some similarities and some differences. In left ventricular failure, we're talking about decreased blood pressure, which leads to decreased tissue perfusion, and you then get decreased exercise tolerance. The muscles just aren't getting the oxygen that they need. The tissues aren't getting the oxygen that they need. So anytime you increase the demand for oxygen, the tissues are going to become hypoxemic, and you're going to have decreased exercise tolerance because of that. When the left ventricle is no longer able to pump blood forward, blood backs up. Where does it back up? It backs up into the left atrium and then into the pulmonary vasculature and the pulmonary veins. So you can get pulmonary edema, which leads to shortness of breath. And then you can also have enlargement of the heart, or cardiomegaly, because again that left ventricle is not able to pump the blood forward, so the blood is backing up and the heart is just getting larger and larger. Then we'll talk about right ventricular failure, which is similar but a little different. Again, if your right ventricle is not able to pump blood into the pulmonary artery, you're going to get poor oxygenation. The blood will back up into the right atrium and then back up into the jugular veins, so you'll get distension of the jugular veins. You'll get hepatic congestion and ascites, and very often you'll get peripheral edema. So some of the symptoms that you may commonly think of as being heart failure symptoms, such as shortness of breath and pulmonary edema, are due to left ventricular failure, and some of the other symptoms, such as peripheral edema, are due to right ventricular failure. So it's important to understand the difference between the two. We should also talk briefly about systolic heart failure versus diastolic heart failure. Now, when we talk about diastolic failure, we're talking about impaired filling of the heart. When we're talking about systolic failure, we're talking about impaired ejection of that blood from the heart. Isolated diastolic failure is less common, as I mentioned. The way it works is you get chronic hypertension, and so the left ventricle has to pump against that increased afterload, and you put a strain on any muscle. What's that muscle going to do? It's going to become hypertrophied. Unfortunately, unlike striated muscle, skeletal muscle, big, thick muscle doesn't mean stronger, better heart muscle. Big, thick muscle means stiffer heart muscle. The ventricles cannot relax normally because they're thickened, and when the ventricles are thickened and they can't relax, the heart cannot fill with blood. The venous return from the pulmonary system cannot fill the left ventricle because that left ventricle has lost compliance and it cannot expand as easily. So you may have a normal ejection fraction, you may be ejecting a normal percentage of blood, but you're not able to fill the ventricle with as much blood, so your fraction of a smaller amount is still a smaller amount, so you're getting forward failure because of your diastolic dysfunction. So that's what we talk about with diastolic heart failure. And again, it's very uncommon to have isolated diastolic heart failure. Most patients who have diastolic heart failure also have some systolic heart failure. So let's talk about the compensation and the compensatory mechanisms used by the body to respond to pump failure. If you have mild pump failure, mild heart failure, the body is able to compensate for that, and it does it in a couple of specific ways, which we'll talk about. But if you have more advanced heart failure, the compensatory mechanisms just can't keep up with that failure, and so you get what's called decompensated heart failure. Sometimes it's said that a patient has congestive heart failure, but then when you look at the patient, they have no symptoms, they have no JVD, they have no edema, their left ventricular ejection fraction may be low, perhaps around 40%, but the patient has no symptoms. They look okay. Well, that's compensated heart failure. There's clearly some systolic failure. The LVEF is low, but the patient has no symptoms because their body's able to compensate for that low ejection fraction. So we need to talk about the specific compensatory mechanisms. And there are two of these. We're going to talk about the renin-angiotensin-aldosterone system and then also the sympathetic system, which are both involved in compensating for heart failure. So first, the renin-angiotensin-aldosterone system. When you have decreased cardiac output, blood pressure is going to drop, renal perfusion is going to drop. You're not able to put enough blood into the kidneys. When the kidneys sense that low blood pressure, when they sense they're being underperfused, the kidneys release a hormone called renin. And then renin leads to increased angiotensin. Now, angiotensin has two actions. The first action is a very potent vasoconstrictor. It's one of the most potent vasoconstrictors in the entire human body. So when you have increased levels of angiotensin, you're going to get vasoconstriction and you're going to increase peripheral resistance. That increases the afterload, which is the load that the heart is seeing, and that increases the work of the heart. So the heart has to work harder to deal with the vasoconstriction and the increased peripheral vascular resistance. The other action of angiotensin is that angiotensin feeds back to the adrenal cortex to cause increased aldosterone secretion. Aldosterone causes retention of sodium and water, which causes increased blood volume. And then you have increased blood that's returning to the heart. But the heart is already failing. That's what triggered this. So when the heart is failing and you increase the amount of blood that's returning to the heart, you're making the heart work harder once again, and you're going to get peripheral edema, you're going to get pulmonary edema because the heart is not able to deal with this increased blood volume. The other important compensatory mechanism is the sympathetic nervous system. When you have decreased cardiac output and decreased blood pressure, what is the body's response to that? Well, it senses the low blood pressure and it increases sympathetic activation. You're going to get more norepinephrine. This is going to have two main effects on the cardiovascular system. First of all, norepinephrine is going to activate the peripheral alpha-1 receptors and cause vasoconstriction. And again, that's going to increase venous return and increase the preload on the heart. So again, that increases the work on the heart. And then the norepinephrine is also going to act on the cardiac beta receptors, which is going to increase the heart rate and create a greater force of contraction of the heart. So again, that's increasing the work that the heart is having to perform. So all of these compensatory mechanisms help to deal with the end result of the low cardiac output, but they actually cause a dangerous cycle in which you have increased work on the heart, and so the heart's working harder and it fails more, and that increases activation of the sympathetic system and the renin-angiotensin system. So that further increases work of the heart, and it's just this downward spiral, as you can see. But all of these create targets for treatment, and as we go through these different drugs used to treat heart failure, you'll see how we're targeting the compensatory mechanisms. We can block angiotensin, we can block aldosterone, we can use beta blockers and block the sympathetic activation. So watch for these as we talk about the various drugs. Another subject we need to touch on is cardiac remodeling or left ventricular remodeling. So when you have this chronic neurohumoral activation, this chronic activation of the sympathetic system or the renin-angiotensin system, you're going to have some remodeling. On a microscopic level, what we're talking about is damage and death of myocytes, hypertrophy of myocytes, and fibrosis, scar tissue and that sort of thing, increased amounts of connective tissue within the heart muscle. At first, it seems reasonable to think that hypertrophied muscle is stronger, but as we mentioned, it doesn't always work that way, and that hypertrophied muscle can't really maintain cardiac performance except very, very little bit at the beginning. Right at first, that remodeling is helpful, and that hypertrophy is helpful, but once it continues, it gets to the point where it's causing stiffness of the muscle and so forth. You also get alterations in ventricular geometry, which worsen the pump action. You know, the heart is sort of eccentrically positioned, eccentrically shaped, and when you start to change the size and the shape of the pump chambers, you're stretching the muscles in ways that are not really natural, and so it's not as an efficient a pump. On a macroscopic scale, the chambers are dilated, the heart becomes more spherical. You see enlargement of the heart or cardiomegaly. Sometimes we talk about a globular heart. It's like a big round basketball, and it's more in the center of the chest, and it just doesn't work as efficiently that way. Ultimately, all this remodeling makes things worse instead of better, and you get more activation of the sympathetic nervous system and more activation of the renin-angiotensin system, which again causes more remodeling. So again, it's a negative system. It's a negative feedback. It's a downward spiral you're going to get into with all this. But this is a pharmacology lecture, so let's talk about how we treat all of this. There are a lot of different goals for treating heart failure. It's important to alleviate symptoms. We're going to relieve some of that edema. We're going to relieve some of that shortness of breath and that exercise intolerance, because that's going to make the patients feel better. We also want to slow disease progression. Heart failure is a progressive disease. It's going to gradually get worse and worse and worse. As we've seen, you have this downward spiral. So we want to slow that progression as much as possible. We also want to improve survival. These patients often have a very limited life expectancy, and we want to improve that. We want to keep them alive and functional as long as possible. We also want to reduce hospitalizations. When these patients decompensate acutely, they get very sick, they wind up in the hospital, sometimes for a few days, sometimes for a week or more, and that's very costly both to the patient and to society in general. So if we can reduce hospitalizations, we're doing everybody some good. So there are a couple of things that we don't find in Lippincott that we need to talk about in terms of classifying or stratifying heart failure. First, I want to look at the American College of Cardiology and the American Heart Association's 4 stages of heart failure. They label these stages A, B, C, and D. In stage A, you have patients who are at high risk for developing heart failure in the future, but they have no functional or structural heart disorder. Stage B, you have a patient with a structural heart disorder, but no symptoms at any stage. In stage C, we have patients with previous or current symptoms of heart failure in the context of an underlying structural heart problem, but they can be managed with medical treatment. And in stage D, we have patients with advanced disease requiring hospital-based support, a heart transplant, or even just palliative care. We get to the point where we say we cannot make this patient better, but we can at least reduce symptoms and palliate them. Now, I don't find this classification system very useful. Why? Well, first of all, stage A, you take a person who has no symptoms and no structural heart disease and saying you have risk factors, you may develop heart failure, so we're going to call you stage A heart failure. Well, for a lot of reasons, it's pretty dangerous to start labeling patients as having diseases that they don't yet have. So I think that's kind of a weird category. You take a patient who had a chest x-ray for preoperative clearance for a knee surgery, for instance. They're going to have a knee replacement surgery, and you find out that they have cardiomegaly. Well, now you have evidence of structural heart disease. Whether or not they have any symptoms, you're going to call them stage B heart failure. So again, I don't know that that makes a lot of sense. And then stage D, you have patients who are end stage. They're basically in a hopeless situation where the only thing left is palliative care or living in a hospital so they can get chronic care or having a heart transplant. So those are people at the really far end of the spectrum. So what does that leave us? Stage C is sort of this catch-all for patients with any stage of symptoms. So I don't find this particular category or this particular stratification system very useful. A much more widely used stratification system is the New York Heart Association Functional Classification, and you'll see this very often, the NYHA classification. They divide heart failure into 4 classes also, class 1, 2, 3, and 4. In class 1, you have patients with no limitation. Again, this is a functional system, so we're worried about function and limitations and symptoms. So in Class 1, you have patients with no limitations. They have no symptoms at all from ordinary activities. So they may have low ejection fraction, they may have evidence of heart failure, but they have no real symptoms from ordinary activities. When they get up and walk around, they exert themselves, they don't get short of breath or anything. In Class 2, you have patients with slight, mild limitation of activity. The patient's generally comfortable at rest or with mild exertion. So they can exert themselves quite strenuously and then they get some symptoms. Class 3 heart failure are patients with marked limitation of any activity, but the patient is comfortable at rest. So if you have a patient who is pretty comfortable at rest, but as soon as they get up and walk, and they may be that they walk 10 feet, they can't get from the parking lot to your office without getting short of breath and having heart failure symptoms, they have Class 3 heart failure. And then Class 4 heart failure means any physical activity brings on discomfort, and sometimes symptoms occur at rest. These are the patients who wake up with nocturnal dyspnea. They're having a lot of symptoms even at rest. So very, very advanced heart failure. So the NYHA classification is very useful, and you will see that again. Let's talk about the treatment options we have for treating heart failure. We're going to talk about non-pharmacological treatment, and then we'll talk about pharmacological treatment. The non-pharmacological treatments include reduction of physical activity, because when you exert yourself, you require more oxygen, and then the heart has to deliver more blood to the tissues, so you're making the heart work harder. So if you can reduce physical activity, you can make the heart work a little less. You're going to reduce sodium intake, because again, patients have a lot of trouble with fluid overload in heart failure. So if you can reduce sodium intake, you can reduce some of the fluid overload. You're going to treat any comorbid conditions. These are things that lead to heart failure. So hypertension, ischemic heart disease, diabetes, other things that are going to contribute to heart failure. You want to treat those optimally if possible. We'll talk about pharmacotherapy, which is the next step of treatment. We want to avoid any drugs that are going to exacerbate congestive heart failure, such as non-steroidal anti-inflammatories. Typically can cause some fluid retention, which can exacerbate CHF. You want to avoid calcium channel blockers, which both depress myocardial contractility and also can very often cause some fluid retention. You want to watch out for certain antiarrhythmic drugs, which can cause some problems. Alcohol can certainly exacerbate congestive heart failure. So you want to minimize drug therapy that is causing problems. And then one other non-pharmacological treatment worth mentioning briefly is called cardiac resynchronization therapy. Sometimes it's called CRT. Sometimes you'll hear about biventricular pacing or the bi-V pacing. This is where you're pacing the septum and the left ventricular wall, the lateral wall of the left ventricle, simultaneously, because in a lot of these patients, their septum and their left ventricular wall are not moving in synchronous motion. They're not moving together. Part of this is just because of stretch and enlargement of the heart and enlargement of the left ventricle, where the heart is just not able to pump efficiently. And so in 25 to 50% of patients, they won't have synchronous movement of the two sides of the left ventricle, so the heart doesn't pump as efficiently. So if you can put pacer leads on those two walls, you can actually pace those so that they will contract together, and you can time that with the atrial pacing so that it all works together. And you can improve mortality and improve symptoms for a lot of patients who have a really low ejection fraction. You know, some patients who come in with ejection fraction of 20, 25%, 30%, something like that. You can really improve symptoms by doing this CRT.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training. It's time for your quick review number 1. Let's get started. What are the differences between left ventricular and right ventricular heart failure? Well, they're actually quite different. Sometimes we lump these two together as just CHF, but depending on which side of the heart is failing will determine which symptom will be most prominent. So let's start with left ventricular heart failure, where you're going to get decreased blood pressure, decreased tissue perfusion, and decreased exercise tolerance. You're also going to get pulmonary edema and cardiomegaly. For right ventricular heart failure, you're going to get poor oxygenation, jugular venous distension, hepatic congestion and ascites, and then peripheral edema. Next question. So we're talking a little bit more here on this section on some of the pathophysiology. So match the following abnormalities with their causes. So jugular venous distension. So that's going to be right heart failure, which we just talked about before, and it's increased venous pressure. Orthopnea. So matched with increased venous return in supine position exacerbates pulmonary vascular congestion. Ankle or sacral edema, right ventricular failure, and this is an increased venous pressure leading to fluid transudation. Dyspnea on exertion, failure of left ventricle output to increase during exercise. And then hepatomegaly, increase in central venous pressure leading to an increase in resistance to the portal flow. So just to kind of recap all this stuff, if you can remember, the left side of your heart is pumping blood to the rest of your body. So if it doesn't work, you're going to have symptoms associated with either hypoxia or just decreased blood flow coming from that left side to the rest of the body. On right side, if it gets in significant failure, is going to decrease your return of blood to the heart. So everything starts backing up in that direction. So right side is going to cause all of the edema problems, all the hepatomegaly problems, all the JVD problems. And then left side of the heart, you're going to have a lot of the exercise intolerance problems and also problems with orthopnea because you're backing up that blood into the lungs. Next question. What is the most likely cause of right ventricular heart failure? So we just talked about how they're different. Well, how do you get right? Well, you start with left ventricular heart failure. So if you think about it, it makes a lot of sense. That left side of the heart, if it's not pumping right, you're getting backup of blood into the lungs. You get pulmonary edema. Eventually, that pressure will then go into the right side of the heart. So left ventricle will probably hypertrophy. It's going to cause more and more pressure going backwards, and then that right heart starts to feel that pressure as well, so then it has to start having the same compensatory hypertrophy. Next. A 63-year-old male has been diagnosed with congestive heart failure. On examination, this patient shows no symptoms, no JVD or edema. His left ventricular ejection fraction is slightly low. This patient overall looks fine and, as mentioned before, is showing no symptoms. How would you describe what is going on with this patient? So this patient has compensated heart failure, and this is not an uncommon occurrence. People can have mild CHF, they get on the right types of medications, and they do pretty well. So CHF, even though it sounds horrible, we use the word failure, people can live relatively normal lives if they're well compensated. Next question. A decrease in renal blood flow will cause what change in renin, angiotensin II, and aldosterone? Well, in general, it will cause an increase in all of these. So think of the scenario in regards to CHF. So in CHF, if you have left-sided ventricular failure, you're not getting enough blood to the rest of your body. So your kidneys feel like they're not getting enough blood. And that's why they increase renin, angiotensin II, and aldosterone, because they feel like they need to hold on to more fluid, or they need to cause vasoconstriction and increase peripheral resistance. So you'll get a sodium and water retention, and you'll also get an increase in peripheral resistance. Next question. What is the New York Heart Association functional classification of heart failure? So this is probably the most important of the classifications, and we went over this during the lecture, but I do want to really pound it into you here because it will be important for testing, and even more importantly, you need to be able to classify your patients appropriately. So Class 1, no limitations, no symptoms from ordinary activities. Class 2, slight, mild limitations of activity. The patient is comfortable at rest or with mild exertion. Class 3, marked limitation of any activity. The patient is comfortable only at rest. And then Class 4, any physical activity brings on discomfort and symptoms occur at rest. So remember that at rest part for Class 4, and then it gets less and less severe as you go further down the classes. Next question. What is cardiac resynchronization therapy? So this is not necessarily a last-ditch effort, but it's not used as first line, obviously. So it's a pacing of the septum and the lateral walls of the left ventricle simultaneously. So you can get a dysynchronous pulse or a contraction when you have bad CHF. It's like one part of the wall isn't quite squeezing at the same time as this side of the wall, so you kind of get this dyssynchronous thing going on. It worsens your CHF. So if you can get everything squeezing at the same time, you can get a better outcome. All right, so that's going to conclude our quick review number 1. Let's get back to the lecture.
All right, so let's talk about some pharmacological treatments for congestive heart failure. We'll talk about each of these classes of drugs. The renin-angiotensin inhibitors, which include ACE inhibitors and angiotensin receptor blockers, beta blockers, diuretics, direct vasodilators, inotropic agents, and aldosterone antagonists. And it's worth mentioning that treatment is very individualized. You're going to fine-tune the treatment to meet the patient's specific needs. Sometimes it'll include several drugs simultaneously. Don't think that you can only pick one class of drugs and then say, well, that didn't work, I'll try this other one. Very often it's going to kind of be a matter of creating a cocktail of drugs that's going to treat all the patient's needs. So the first big category of drugs to talk about are the inhibitors of the renin-angiotensin system. These include ACE inhibitors and angiotensin receptor blockers, or ARBs. So let's have a brief review of the renin-angiotensin-aldosterone system. The juxtaglomerular cells release renin in response to decreased renal perfusion due to low blood pressure and also due to sympathetic stimulation. And as we've already mentioned, both of these are occurring in heart failure, so renin levels are going to be very, very high. The action of renin is it's going to cleave angiotensinogen into angiotensin 1. Then you have another enzyme called angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2. And as I mentioned, angiotensin 2 is that potent vasoconstrictor. Angiotensin 2 is also going to stimulate aldosterone production, which leads to sodium and water retention. So high levels of angiotensin 2 and high levels of aldosterone are going to favor cardiac remodeling and fibrosis, as we've already mentioned. So we blockade this angiotensin system with 2 different classes of drugs. The first is the angiotensin converting enzyme inhibitors, or ACE inhibitors. Sometimes they're just called ACEs. The drugs we're talking about include captopril, enalapril, fosinapril, lisinopril, quinapril, and ramipril. So if it ends with PRIL or pril, you pretty much know it's an ACE inhibitor. As the name suggests, these work by inhibiting angiotensin converting enzyme. And the actions of these drugs include decreased vascular resistance and decreased venous tone, so they're going to lower blood pressure. You're going to have less angiotensin 2, so you have less vasoconstriction. And they also are going to diminish the rate of bradykinin inactivation. Bradykinin is a potent vasodilator, so if you can keep bradykinin around longer, you have more vasodilation. ACE inhibitors also lower vascular resistance and increase cardiac output as a result. You're going to have less angiotensin 2, so you'll have less aldosterone. And overall, you're going to have decreased morbidity and mortality in heart failure patients. These have been proven to reduce morbidity and mortality in heart failure patients. So you'll very often see these used in patients with any stage of heart failure. So how do we use these therapeutically? Well, for a lot of patients who have mild dyspnea, no volume overload, just the beginning stages of congestive heart failure, you may use an ACE inhibitor as monotherapy. Again, it's proven to reduce morbidity and mortality, so this is a good thing. If you have patients who are asymptomatic but have very low left ventricular ejection fraction, less than 35%, we're going to give it to those patients. We're going to give them an ACE inhibitor because it's going to reduce the progression to symptomatic CHF. ACE inhibitors are also used to treat hypertension. They're used after myocardial infarction. And they're also used to reduce proteinuria in patients with renal disease and diabetic nephropathy. So there's a lot of different uses for these drugs other than heart failure. Let's talk about the pharmacokinetics of ACE inhibitors. They're oral drugs. A few of them can be given IV, but for the most part these are oral drugs. Food may decrease absorption after oral administration, so very often you need to give this drug with instructions to the patient to take it on an empty stomach. Most of these drugs require hepatic hydrolysis to become active, so they're technically prodrugs. They have to be activated by the liver in order to become active. Most of them are renally excreted. The half-lives can be widely variable, from 2 hours to 12 hours. So a lot of these drugs have to be dosed twice a day, but some of the newer agents can be dosed once a day because they have longer half-lives. In terms of adverse effects, well, these are drugs that are going to lower blood pressure, so in some cases you can get hypotension. You can get postural hypotension, where you give this to the patient and all of a sudden they start standing up and they get lightheaded and dizzy and they pass out. It's very dangerous, so patients need to be warned to be careful about this. And very often we'll start with very small doses and titrate this up to a larger dose. Another important adverse effect of ACE inhibitors is something called angioedema. which is where you get edema in the soft tissue, usually in the mouth, the lips, the tongue, the throat. This is potentially life-threatening if there's any kind of airway compromise, and you never know how quickly it's going to progress. So a patient may come in with just a little bit of angioedema of the lip, and you say, it's not that big a deal, go home, and then it really progresses, and overnight they asphyxiate because they've had progression of their angioedema. So this is an emergency. You need to warn your patients to watch for this, and if they have any signs of it, you want them to go to the emergency room to get treatment. Generally, ACE-induced angioedema is thought to be due to elevated bradykinin levels, as we already mentioned. Angioedema is usually more common in blacks than in whites, so you can warn your patients about that appropriately. You have to stop the offending drug, and you have to avoid all ACE inhibitors in the future, because you never know, just because they reacted to this one doesn't mean the other ones are safe. They could have angioedema from any ACE inhibitor. Some studies suggest that angiotensin receptor blockers, which we'll be talking about next, can also cause angioedema in susceptible patients. So if a patient has angioedema from an ACE inhibitor, you may have to take them off of all of these drugs. Treatment for angioedema often includes hospitalization and treatment with epinephrine and antihistamines, both H1 and H2 blockers. Often we'll treat with steroids to reduce the inflammation, although there's not really a lot of data to support this regimen. But it's one of those things where this is a potentially life-threatening condition. You want to do anything that might be beneficial to the patient. So that's it on angioedema, but we have a few more adverse effects from ACE inhibitors to discuss. One of them is hyperkalemia. Another is renal insufficiency. So you need to monitor labs close for high potassium and for renal insufficiency, or rising creatinine and BUN. ACE inhibitors can also cause a persistent dry cough, this kind of hacking, throat-clearing cough. This is thought to be due to elevated levels of bradykinin. This is not a dangerous side effect, but it is bothersome. I often tell patients when they're starting an ACE inhibitor, watch for angioedema. It's rare, but it could kill you. And watch for a dry cough. If you start coughing after the first week or two you've been on these drugs, it may not be just your allergies acting up. It may be the drug. And very often you stop the drug and the cough goes away quickly. So it's worth knowing about, worth reminding or warning your patients about. And then the last thing about ACE inhibitors, these are fetotoxic. They're dangerous to fetus. So you don't want to give them to a pregnant patient. These are contraindicated in pregnancy. And often women who have hypertension, usually when we're talking about heart failure, we're talking about older patients. But if you're treating a woman with hypertension with an ACE inhibitor, if they think they might become pregnant, you probably want to take them off of the ACE inhibitor and switch them to a safer antihypertensive drug. So the next group of drugs to talk about are the angiotensin receptor blockers, or ARBs, they're commonly called. These again are acting against the renin-angiotensin-aldosterone system in a different way. The drugs we're talking about include losartan, candesartan, valsartan, telmisartan, olmesartan, and irbesartan. So just like the ACE inhibitors, if you hear pril, you think ACE inhibitor. If you hear sartan, you think ARB. The mechanism of action of these drugs, they are competitive antagonists of the angiotensin type 1 receptor. So unlike the ACE inhibitors, which block the conversion of angiotensin 1 to angiotensin 2, this is going to actually block the angiotensin receptor. So you get a more complete blockade of angiotensin action than you do with an ACE inhibitor. And these drugs have no effect on bradykinin levels. They're not going to maintain a high bradykinin level. So theoretically, you shouldn't have much cough, and theoretically, you shouldn't have any angioedema. But as I've already mentioned, there seems to be some cross-reactivity, so that may not be the case. The therapeutic uses of ARBs, they're widely used for hypertension. They're often used to treat congestive heart failure and patients who have had an MI, especially if they're intolerant to ACE inhibitors. ACE inhibitors generally carry the first indication for post-MI patients and for congestive heart failure, but there's a lot of thinking that if you can't take an ARB, or rather if you can't take an ACE inhibitor, you may as well give an ARB. Some ARBs, such as valsartan and telmisartan, have clearly demonstrated efficacy for congestive heart failure. Other ARBs, including irbesartan and olmesartan, have tried to demonstrate efficacy. There have been studies to look at, are these effective in preventing or in lowering morbidity, mortality in patients with CHF, and they have failed to show any benefit. So it may not be a class effect. The pharmacokinetics of ARBs, these are oral drugs. Again, they're usually given once a day, so there may be a little benefit over the ACE inhibitors, which sometimes have to be given twice a day. Most of the drugs do not undergo any type of first-pass hepatic metabolism to their active drug, the active metabolite, but losartan does. It has to be activated into its active form. The adverse effects of ARBs are very similar to ACE inhibitors, except for very, very low risk of cough. They can still cause hypotension. They can potentially still cause some angioedema. You can get hyperkalemia and renal insufficiency, so you have to monitor the same labs. And these are also contraindicated in pregnancy because they're toxic to the fetus. The next group of drugs are the beta blockers, or beta adrenergic antagonists. The drugs we're talking about for congestive heart failure are carvedilol and the long-acting form of metoprolol. These are the only two beta blockers that have FDA approval for the treatment of congestive heart failure. In general, this class of drugs, beta blockers, is discussed much more generally in the lecture on adrenergic antagonists. So if you want more detail on beta blockers, you might watch that lecture. But we're talking about these two drugs because they are used to treat congestive heart failure. The mechanism of action, these are beta adrenergic antagonists. They have negative inotropic effects, so they're going to reduce cardiac output. They're going to reduce the intensity and the strength of the cardiac contraction. It's a negative inotrope. So it may seem a little strange to give these patients with congestive heart failure who already have depressed myocardial contractility a drug that's going to further depress myocardial contractility. But there have been several clinical studies that have clearly demonstrated that beta blockade improves systolic function and reverses cardiac remodeling, because it's that constant chronic activation of the sympathetic system that's so dangerous and that so promotes cardiac remodeling. So if we can block some of that response, we can block and decrease some of the remodeling. The therapeutic uses of beta blockers, all patients with heart disease should be on a beta blocker, except those who are high risk but have no symptoms may not get any benefit from a beta blocker, and patients who are in acute decompensated heart failure, patient who comes into the hospital with florid heart failure, pulmonary edema, short of breath, hypoxia, peripheral edema, just really sick from their congestive heart failure. You don't start those patients on a beta blocker because it does have some negative inotropic effect, and that could be dangerous. You wait until the patient is compensated, they're stable as an outpatient, and then you put them on a beta blocker. And again, you probably start with a low dose and titrate it up. As I mentioned, carvedilol and metoprolol have both been shown to reduce morbidity and mortality associated with heart failure. The adverse effects, again, these are going to slow down the heart. They're going to lower the blood pressure, so you could get some dangerous bradycardia. You could get some hypotension. You could get patients who are a little bit dizzy and have some lightheadedness and near syncope from beta blockers. Beta blockers will also cause patients to feel very fatigued and run down and tired. Sometimes they can cause some erectile dysfunction. So there are a lot of symptoms that patients are going to feel almost immediately, and you need to warn them about that. And that's one reason why we start on a low dose and then titrate it up. Metoprolol is cardioselective. It's more selective for beta-1 receptors at low doses, but then when you get to higher doses, it becomes less and less selective. Metoprolol can cause decreased glycogenolysis and decreased glucagon secretion. The beta-2 blockade that you get at higher doses can cause some bronchospasm, it can cause some reflex peripheral vasoconstriction, and it can cause some sodium retention. So you need to really be careful when you're using high doses of the long-acting metoprolol. Now, carvedilol blocks both the beta receptors as well as alpha-1 receptors. It's a mixed alpha and beta antagonist. So it does not cause peripheral vasoconstriction. That alpha-1 blockade can actually cause some vasodilation, which can be helpful. And carvedilol should have no effect on blood glucose levels, so that can be beneficial. The next class of drugs is the diuretics. Usually when we're talking about treating congestive heart failure with diuretics, we're talking about loop diuretics, including furosemide, torsemide, and bumetanide. Sometimes we use thiazide diuretics, such as hydrochlorothiazide and metolazone. And sometimes we use spironolactone, which we'll talk about toward the end of the lecture. There's an entire lecture focused on nothing but diuretics, and that's chapter 22 of Lippincott. So I'm going to limit the discussion here to just a few points about diuretic use. The actions of diuretics in patients with congestive heart failure include relieving pulmonary congestion and peripheral edema. So we're treating the important symptoms that patients are going to complain about. My ankles are swelling, I can't breathe when I'm exerting myself, and so forth. So these are both symptoms of volume overload. They have sodium retention, they have fluid retention, they have too much volume. Their heart can't handle all that volume, so it leaks out into the interstitial tissue. They're going to reduce the symptoms of orthopnea, or shortness of breath when you're lying down, and they're going to reduce the symptoms of paroxysmal nocturnal dyspnea. which is a symptom described as becoming very short of breath in the middle of the night. Patients will wake up short of breath and have to sit up to breathe. So that's something you'll ask patients about when they have congestive heart failure, or they talk about being short of breath, or you think they may have congestive heart failure, you're trying to kind of tease it out. You say, well, are you more short of breath when you're lying down, or do you feel better if you sit up? And often they say, yeah, well, that's orthopnea. Or you'll say, do you ever wake up at night gasping for breath and have to sit up on the edge of the bed to breathe? They say, sure, yeah, doc, how'd you know? Well, that's paroxysmal nocturnal dyspnea, and both of those are classic symptoms of CHF. Now, they can be seen in any syndrome that causes volume overload, but they're classically associated with congestive heart failure. Diuretics also reduce plasma volume. They're going to decrease the venous return to the heart, which is your preload, so they're reducing preload, and that decreases cardiac workload and decreases myocardial oxygen demand, which is a good thing. And also, by decreasing plasma volume, they're going to reduce the blood pressure, which is going to reduce afterload, which also reduces the work of the heart. The next group of drugs are the direct vasodilators. We're talking about some very different types of drugs here. We're going to lump them all together because they all have the same action or the same end result, but they do it in very different ways. The drugs we're talking about are the nitrates, including isosorbide dinitrate and sodium nitroprusside. And then other drugs include hydralazine and a drug called nasiratide. Talking about each of these drugs separately in terms of their mechanism of action, the nitrates are also discussed in the lecture on anti-angina drugs. The nitrates are converted to nitrite and then to nitric oxide, which leads to vascular smooth muscle relaxation, and primarily venous smooth muscle relaxation. Hydralazine is a drug which also causes vasodilation, and it's covered in the antihypertensive lecture. The mechanism of action of hydralazine is not well understood, but it seems to interfere with the second messenger, and it impairs calcium release from the sarcoplasmic reticulum of smooth muscle, so you get some decreased vascular tone and some vasodilation that way. And so it relaxes arteries and arterioles. So nitrates primarily are relaxing or dilating the venous vessels, and hydralazine is primarily dilating the arterial vessels. And then the other drug to talk about is nasiratide. Nasiratide is very interesting. It's a synthetic form of a chemical called BNP, or brain natriuretic peptide, sometimes called B-type natriuretic peptide. This is a peptide that's secreted by myocytes in the ventricles in response to stretch. So if you have stretch of the heart because of increased blood volume in the heart failure, the left ventricle is not pumping the blood forward, so the blood has nowhere to go, so the heart is just stretching and the ventricle is stretching. You're going to have high levels of this BNP chemical. So we use it diagnostically. If a patient comes in with a history of congestive heart failure and you look at their chest x-ray and they maybe have some pulmonary edema and you're wondering, is there something else going on causing this patient's presentation at the emergency room, or are they just having congestive heart failure, you can check a BNP level and see if they have very high BNP level. That means they're probably in acute heart failure. If their BNP level is low or normal, that means there's probably something else going on. You need to be careful, though, when you're ordering a BNP level, that the people who are taking your orders down, whether written or a verbal order, don't misunderstand you to be ordering a BMP, or a basic metabolic profile, or basic metabolic panel. Sometimes you'll order a BMP, meaning you want electrolytes and renal function, and the nurse mishears you and comes back with a BNP, which is this B-type natriuretic peptide. It's not very helpful in that situation, so you need to be careful when you're ordering this lab. But BNP and the synthetic version called nasiratide cause an increase in cyclic GMP in smooth muscle, which is going to reduce vascular tone, both in the arteries and in the veins. It also causes some diuresis. It's called a natriuretic peptide, so you can kind of guess from that it's going to cause expulsion of, or excretion rather, of sodium and excretion of water that follows the sodium. Nasiratide is given parenterally. It's not really clearly proven to be beneficial in congestive heart failure, but there are some people who really are proponents of this drug, so it can be used, but it's not clearly proven to benefit outcomes. So how do these various vasodilators help you if you have congestive heart failure? Well, if you dilate the veins, so primarily we're talking about nitrates and nasiratide, If you dilate the veins, you're going to decrease cardiac preload by increasing the venous capacitance. The venous system can hold more blood, so less blood is shunted to the heart, which is failing. If you dilate the arteries, so again we're talking about hydralazine and naseritide, you're going to reduce systemic arteriolar resistance and decrease afterload. So the heart is not having to pump against such a great force of all this vascular resistance, so the heart doesn't have to work as hard. So dilation of the veins and dilation of the arteries have very different effects on the heart, but the outcome is the same, decreased work of the heart. The adverse effects of vasodilators, well, you're going to get hypotension. That's one of the big things you have to watch for is hypotension. Nitrates can commonly cause some headache due to venous dilation, so you need to be aware of that as well.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
How you doing? I'm Jimmy Snake Eyes, and I got a very important question for you. Which two beta blockers are indicated for the treatment of chronic heart failure? That's right, carvedilol and metoprolol. Hey, wait a minute. Which kind of metoprolol? Long-acting metoprolol. Goes by the brand name Toprol XL. Don't get sloppy like that. Stay on your toes. I got my eyes on you. All right, wise guy. Which beta blocker is indicated for acute decompensated CHF, huh? Oh, gotcha! Beta blockers are contraindicated in acute CHF because they depress myocardial contractility. Pay attention, will ya? I tell you what, kids these days, they think they know everything. Why, I oughta...
All right, we're back. It's time for quick review number 2. Let's get started. ACE inhibitors decrease circulating levels of angiotensin II. What effects are seen with a decrease in angiotensin II? So, angiotensin II is known as one of our most potent vasoconstrictors. So let's find out what else happens. So you get output of sympathetic nervous system is decreased, increase in vasodilation of vascular smooth muscle, decrease in aldosterone production, increase in bradykinin, and retention of sodium and water is decreased. Next question. A 58-year-old male presents to your office complaining of a persistent dry cough. While getting a complete history and physical, the patient mentions he just started on a new medication for his high blood pressure, but he can't remember the name. What class of antihypertensive drugs is likely to be the cause of his cough? So this is an easy question. The answer is an ACE inhibitor. And you'd think this would be something we would catch all the time, but not uncommonly. I'll have a new patient who comes to me who says, boy, I've had a cough for 3 years, and I've been told it's because of my allergies, and on and on and on. And then I go through their medication list and I go, well, I see you're on an ACE inhibitor. Did anyone ever mention that that can cause a cough? And I go, no. And I'll say, well, why don't we stop it for a week and maybe replace it with something else for a while. And then they come back and say, I stopped coughing for the first time in 3 years. Thank you very much. So be aware of that because it is out there. Next question. What are some therapeutic uses for ARBs, or the angiotensin receptor blockers? Well, it's pretty much the same thing for the ACE inhibitor. So if you can remember one, you can remember both. So hypertension, congestive heart failure, post-MI, in patients who are intolerable to ACE inhibitors. So that's the key to the ARBs, in my opinion, at this point in time, is that basically you're going to use them as ACE inhibitors, but if you have the choice between an ACE inhibitor and an ARB, we generally choose the ACE inhibitor. And why is that? Are they any better? No, they're not any better, but they're a lot cheaper. So in the real world, we use a lot of ACE inhibitors. If a patient doesn't tolerate an ACE inhibitor, specifically for the cough, that's when we generally switch over to the ARBs. Not everyone does this. Some people will still start with ARBs as first line. But I would say in general, patients prefer to use a lot cheaper drugs, especially if you're getting the same outcome. Next question. What 2 beta blockers have been FDA approved for the treatment of congestive heart failure? Well, this is going to be carvedilol and long-acting metoprolol. Next question. How is carvedilol different from metoprolol? So we just said they're both beta blockers. How are they different? Well, carvedilol is quite a bit different because it not only blocks beta receptors, it also blocks alpha-1 receptors. So how, if we think physiologically, how does this help us? Well, remember how alpha-1 is concerned with our peripheral vasoconstriction. So by blocking those alpha-1, you can help promote peripheral vasodilation. So you have an even increased improvement in your blood pressure and decreasing your afterload. Next question. What are some adverse effects of beta blockers? So there's quite a few. Some people take beta blockers and they do absolutely fine, and then I've had some people who take beta blockers and their life is then miserable. So always warn your patients about these adverse effects because they can be a big deal. First and foremost that you always need to be aware of is bradycardia. Now, patients aren't always aware of this symptomatically. Sometimes I've had patients come in and their heart rate is 45 and they're sitting there, I feel fine. I'm like, are you sure? So be aware of bradycardia, hypotension, especially orthostatic. You'll have your older patients, every time they stand up, they get a little dizzy, but you have to be very careful because you don't want to cause more harm than good with your treatment. Dizziness, lightheadedness, we just mentioned. Fatigue is a big one. You'll have some people who are virile, young people, and they take a beta blocker and they are zapped. They have no energy, and that beta blocker is what's causing it. Erectile dysfunction is also a big deal. Obviously, our male patients aren't going to be too happy if we cause that problem. Next question. How do diuretics help CHF? So let's talk about this. So decreased plasma volume will lead to decreased venous return to the heart. They will decrease cardiac workload and oxygen demand. And then it also will decrease afterload by reducing plasma volume and a decrease in blood pressure. So it's helping both our afterload and our preload because we're decreasing that volume and we're helping with decreasing the need for the heart to push out extra volume. Next question. List the vessels that are dilated when using the following medications. So these are direct-acting vasodilators, and we're choosing between arteries and veins and both. Hydralazine will work mostly on arteries, so remember that one. Naziretide will work on both, so arteries and veins, and then nitrates will work primarily on veins. Next question. A patient comes into the ER complaining of severe shortness of breath and palpitations. Physical exam reveals swelling in the legs, ankles, and feet. You suspect acute heart failure. What test should you order to help confirm your suspicion? So there's a couple different things you can do. Now, you can check a chest x-ray. You can look for pulmonary edema there. You can look at electrolytes. You can look at a lot of different things. One test that we're looking for here is the BNP, or the B-type natriuretic peptide. So that'll give you an idea if that heart is being stressed to the point where it's releasing this peptide. So BNP is what you want to order in this situation, because if it's negative, then there's a good chance this is not a CHF situation. All right, so that's going to conclude our quick review number 2. Let's get back to the lecture.
The next group of drugs are the inotropes, or inotropic drugs. You've already heard we were talking about drugs that are used to treat patients with MI, drugs that are used to treat patients with hypertension, but these inotropes are primarily used for congestive heart failure. You're not going to see them used in too many other circumstances, really. The drugs we're talking about include digitalis, or digoxin, beta agonists such as dobutamine, phosphodiesterase inhibitors such as amrinone and milrinone. And all of these work in the same basic mechanism. They all enhance cardiac muscle contractility, and therefore they increase cardiac output. And they act by different mechanisms, but they all increase cytosolic calcium concentrations, and that enhances the contractility of the cardiac muscle. So we need to backtrack a little bit, have a little sidetrack here, and look at the physiology of cardiac contractility. So cardiac cells have rhythmic action potentials. They're rhythmically depolarizing and repolarizing, and this is regulated by pacemaker cells and the conducting cells within the heart. When these cells depolarize, they open up voltage-gated calcium channels in the cell membranes, and that allows calcium to flow from extracellular space into the cytoplasm of the cell. When this calcium comes into the cell, it triggers release of calcium from the sarcoplasmic reticulum within the cells, and this increase in calcium initiates contraction of the myocardium. The force of the myocardial contraction is directly related to the concentration of the free intracellular calcium. So if you have more calcium in the cell, you're going to have a stronger contraction of the muscle. That's just basic how muscles work. Any agent that's going to increase the amount of calcium within the cell is going to increase the force of contraction. This is called an inotropic effect, or we talk about drugs being a positive inotrope, meaning it's going to increase the inotropic effect. It's going to increase the force of myocardial contractility. Sometimes we'll talk about drugs being negative inotropes. They suppress or reduce myocardial contractility. If intracellular calcium levels remained high, the muscles would be in a constant state of contraction. They'd never be able to relax. And that's obviously not the way the heart works. It's got to contract and then relax, and contract and relax. That's basic, right? Well, in order to do that, you have to be able to remove that calcium from the intracellular space. And there are two basic mechanisms to remove calcium. The first, the simplest one, is that calcium is taken up by the sarcoplasmic reticulum. So the SR releases calcium into the cytosol, and then it takes it back up rather quickly. And it's stored for the next contraction. The other mechanism for removal of calcium involves the sodium-calcium exchanger, also known as the sodium-calcium antiporter. So we see that calcium is brought into the cell through the voltage-gated calcium channel, and the calcium then can be taken up into the sarcoplasmic reticulum, or it can be used to trigger a myocardial contraction here. But then this sodium-calcium antiporter is going to pump calcium against its concentration gradient out of the cell. And at the same time, it's going to pump sodium down its concentration gradient into the cell. Well, once it pumps that sodium down its concentration gradient, it's very important for the cell's polarity to get that sodium out of the cell. So we have this sodium-potassium ATPase, which uses energy, it uses ATP to pump sodium up its concentration gradient, against its concentration gradient, out of the cell. And at the same time, it's pumping potassium up its concentration gradient into the cell as well. So that brings us to our first inotropic agent, which is digitalis. Digitalis is a chemical that's derived from the foxglove plant. The only form available here in the U.S. is called digoxin. These are also known as cardiac glycosides. The mechanism of action of digitalis is very interesting. Digitalis inhibits the sodium-potassium ATPase, which leads to a relative increase in the intracellular concentration of sodium. When sodium is higher inside the cell, that means the sodium-calcium antiporter is not going to be pumping sodium into the cell, and therefore it's not going to be pumping calcium out of the cell. So you're going to have an increase in intracellular calcium, which leads to an increase in myocardial contractility, and therefore an increase in cardiac output. So therapeutically, we use digitalis for patients with severe left ventricular systolic dysfunction. It's not indicated in patients who have diastolic dysfunction or right-sided heart failure. Patients who have mild to moderate heart failure don't really require digitalis, and it's important that we don't give digitalis to patients who don't really need it because it is a potentially hazardous drug, which we'll talk about. Talking about pharmacokinetics for digoxin or digitalis, it has a relatively long half-life, about 36 hours, so this is going to stay in the body a long time. It also has a large volume of distribution, so we have to use loading doses when the patient comes into the hospital and needs to be started on digoxin. Sometimes we call this digitalizing the patient. We have to use a large loading dose to get their level up to a therapeutic dose relatively quickly. These drugs are renally excreted, so you have to adjust the dose in patients who have renal failure. There's another digitalis glycoside that's not available in the U.S. called digitoxin. It has a hepatic metabolism as opposed to a renal excretion, so that's important to know about. The adverse effects associated with digitalis are very important. This is highly testable material. Digitalis has a very narrow therapeutic index, which means that there's not much difference between the therapeutic dose and the toxic dose, so you can really hurt patients with this if you're not careful. In terms of effects on the heart, digitalis can cause almost any form of arrhythmias. It can cause bradycardia, an AV block or atrioventricular block. It can cause premature ventricular contractions or PVCs, ventricular tachycardia, ventricular fibrillation, atrial arrhythmias, so really any type of arrhythmia. Patients who have low intracellular potassium are predisposed to these arrhythmias. Digitalis also causes gastrointestinal side effects, commonly nausea and vomiting, but also anorexia. Digitalis can cause central nervous system effects such as fatigue, confusion. It can cause vision disturbances, altered color vision, blurred vision. So that's something else that you'll see very often. A patient on a test will present with blurred vision or altered color perception and nausea and vomiting. And the question you have to ask, are they on digitalis, and if so, are they toxic? We've already mentioned a couple of factors that can predispose to digitalis toxicity. We talked about electrolyte disturbances, and low potassium or hypokalemia can predispose to arrhythmia. High calcium or hypercalcemia and low magnesium or hypomagnesemia can predispose to digitalis toxicity. Certain drugs can cause digitalis toxicity. Specifically, quinidine, verapamil, and amiodarone will actually displace digoxin from their protein binding sites, and they'll also compete for renal excretion. So you can have an increase in digoxin levels by as much as 100% or double the digoxin level when you give one of these drugs concomitantly. Drugs such as potassium depleting diuretics are going to lower potassium. Also corticosteroids and other drugs that may lower potassium are going to increase the risk of toxicity associated with hypokalemia. And then certain diseases such as hypothyroidism, renal failure, hypoxemia, myocarditis, these will all predispose patients to digoxin toxicity. In terms of managing digitalis toxicity, we're going to monitor digoxin levels very closely and adjust the doses as needed. We're also going to monitor potassium levels and supplement as needed. And if there's clinical toxicity, if you've got a patient who's on digoxin and they're starting to have some nausea and they're starting to have some vision disturbances, you want to go ahead and stop the digoxin if there's any clinical suspicion of digoxin toxicity. It's just a dangerous drug. You have to be really careful with it. In emergency situations, you can use an antibody preparation which can bind and inactivate the drug. This is called digoxin immune fragments, or digibind is what they're called. They're very expensive. They're very infrequently used. I've never seen them used for digoxin toxicity because they're very expensive and there are cheaper ways to treat this. But it is one of those things that might turn up on a test. The next inotrope to talk about is a beta-adrenergic agonist, which is called dobutamine. Second to digitalis, it's the most common inotrope that's used. Its mechanism of action is that it's going to increase cyclic AMP. Cyclic AMP activates protein kinases which phosphorylate the slow calcium channels. So you're going to have an increased calcium influx. So you have higher levels of calcium in the cell and therefore increased contractility. This is going to increase cardiac output, but it can also cause tachycardia. So dobutamine can cause some rapid heart rate, so that is potentially dangerous. Dobutamine is given by IV infusion, usually in hospitalized patients. It's often used for patients who have cardiogenic shock or extremely low blood pressure because the heart is just rapidly failing. So you can use dobutamine in that situation. The adverse effects, you have to use dobutamine in caution in patients who have atrial fibrillation because of increased AV nodal conduction. And dobutamine can also cause anxiety and headaches and tremor and elevated blood pressure. The other two inotropic drugs to talk about are both phosphodiesterase inhibitors, and they're called amrinone and milrinone. The mechanism of action is the same as dobutamine. It increases cyclic AMP, which is going to increase the phosphorylation of the calcium channels and cause an increase in calcium and an increase in contractility, and therefore an increase in cardiac output. These are also IV drugs. They're usually used short-term for patients who have refractory heart failure. Long-term use can be associated with an increase in the risk of mortality from these drugs. But short-term use of milrinone intravenously is not associated with an increase in mortality. So short-term, it's a pretty safe drug. Long-term, it can be dangerous. And then the last drug we'll talk about in the treatment of heart failure is spironolactone. It is a direct antagonist of aldosterone, and it's going to prevent salt retention, prevent fluid retention. It also will prevent myocardial hypertrophy to a certain extent because aldosterone is very important in that cardiac remodeling process we talked about. And because it is a potassium-sparing diuretic, it's going to prevent some of the hypokalemia that we may see with diuretics. The therapeutic uses of spironolactone, in terms of congestive heart failure, it's mostly reserved for patients with very advanced heart failure. It's sometimes used as a diuretic. It is the diuretic of choice in patients with cirrhosis, and it's sometimes given along with diuretics that are going to cause potassium depletion, such as loop diuretics, in order to counteract some of that potassium depletion. Spironolactone can also be used in patients who have secondary hyperaldosteronism. So they have high levels of aldosterone. You want to blockade that with an aldosterone antagonist. The pharmacokinetics, this is an oral drug. It does induce cytochrome P450, so that's important to know. The adverse effects, it can cause gastrointestinal problems such as gastritis and peptic ulcers. It can also cause some nausea. It causes a lot of endocrine effects. It causes gynecomastia in men. It causes menstrual irregularities in women. And it causes decreased libido. It can cause some lethargy and confusion. And, as I mentioned, it's a potassium-sparing diuretic, so it can cause some hyperkalemia. So you have to watch potassium levels. So briefly, I want to go over the order of therapy used for all these different drugs. The American College of Cardiology and the American Heart Association have come up with some guidelines to suggest which drugs should be used in which order. The first drugs are generally the loop diuretics. These are used in patients with overt heart failure. They help relieve the signs and symptoms of volume overload such as dyspnea and peripheral edema. Next, you want to move to ACE inhibitors, or ARBs, if the patient is intolerant to ACE inhibitors. These are added after you optimize diuretic therapy, and you're going to gradually titrate the dose to the maximum tolerated dose, or the dose that provides optimization of cardiac output. Following ACE inhibitors or ARBs, usually you're going to go to a beta blocker because you want to have that improvement in morbidity and mortality that we talked about. In some patients, you may go to digoxin or digitalis next. Usually this drug is reserved for patients who have symptoms of heart failure despite multiple drug therapy on all these other classes of drugs. If they have systolic dysfunction or atrial fibrillation or an S3 heart sound, you may put them on digoxin before the beta blocker. And then toward the end, you're going to use things like spironolactone, vasodilators, and even the biventricular pacing or the transplant that we talked about as sort of a last resort for treatment of heart failure.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide.
Which adverse effects are associated with digitalis toxicity? This is easy. Even the medicine fleas know this. Cardiac arrhythmia, vomiting, visual disturbances, and confusion. Good grief. How can you possibly have gotten this far in your training and not know that?
All right, it's now time for our quick review number 3. Let's get started. Contractility of cardiac muscle is directly related to what ion? This is an easy one. This is just calcium. Describe the mechanism of action for digitalis and how it leads to an increase in cardiac output. Well, it inhibits the sodium-potassium ATPase pump, and it increases intracellular concentrations of sodium. So this sodium-calcium antiporter will not pump sodium into the cell or calcium out of the cell. So ultimately, this increases the intracellular calcium. And with increased calcium, you're going to have increase in myocardial contractility and increased cardiac output. Next question. Digitalis is not indicated for patients with what type of heart failure? So this is a great question. You're going to get this on the wards or on a test question. Diastolic heart failure, right-sided heart failure, and mild to moderate heart failure. So you're not going to use digitalis or digoxin, right side of the heart, diastolic, or mild to moderate. So you're going to use a lot of other medications before you start grabbing for the digitalis. Next question. How do medications such as quinidine, verapamil, and amiodarone cause digitalis toxicity when used concurrently? So they displace digoxin from tissue protein binding sites. So you have more circulating digoxin, and then it competes with digoxin for renal excretion. And then digoxin levels will increase. Next question. What are the adverse effects of dobutamine? So dobutamine will increase the heart rate, so you'll get tachycardia, you'll get anxiety, headaches, tremors, and elevated blood pressure. Next question. Spironolactone is a direct antagonist of aldosterone and will thereby prevent what 3 things? Well, it'll prevent salt retention, it'll prevent myocardial hypertrophy, and it'll also help prevent hypokalemia. So that's why we call it a potassium-sparing diuretic. You're holding on to your potassium. Next question. What are the adverse effects of spironolactone? So there's regular GI stuff like gastritis, peptic ulcers, and nausea. One good test question is going to be on endocrine effects of spironolactone. So you can get gynecomastia, menstrual irregularities, decreased libido. Lethargy and confusion are less often found, and then hyperkalemia can be a big deal. So sometimes we want to get rid of our potassium, and that spironolactone won't let us. Next question. What are the common EKG changes seen with digitalis treatment? So this is a tough one. It's hard to remember, but try to get as much in as you can. You get flattening or inversion of the T waves, QT interval shortening, scooping ST segments with ST depression in the lateral leads, and then increased amplitude of the U waves. Next question. What is the mechanism of action and clinical use of eplerenone? So we didn't talk about this one in the lecture. It's just another selective aldosterone receptor antagonist. So it's very, very similar to spironolactone. So when do we use it? Well, we use it mostly in patients with more severe CHF with low left ventricular ejection fraction after a myocardial infarction. So it's got a little bit more kick to it, but it can lead to some more complications as well. Next question. What are the signs and symptoms of digitalis toxicity? So there's a lot of signs and symptoms of dig tox or digitalis or digoxin toxicity. First is electrolyte abnormality. So first you need to remember hyperkalemia. So acute toxicity, hyperkalemia. Now this is a little bit tricky because in chronic toxicity, so say if someone's just over a long period of time taking too much digitalis, you have to worry about hypokalemia. So low potassium can be a problem because it can increase the patient's susceptibility to the toxic effects of digoxin. So still be aware of hypokalemia, especially if someone's been on the same dose of digitalis for a long period of time. It's just slowly accumulated. The next part, GI effects. So you'll often get a lot of nausea, a lot of vomiting, and some abdominal pain. Neurological effects, you can get confusion and weakness. Visual changes, this is a great test question. What type of visual changes will you see with digitalis toxicity? Well, you'll get sort of this yellowish halo, yellow color vision change. So if you hear yellow, think of digitalis toxicity. You can also get scotoma, so you can see these little black spots. And then blindness is a possibility. And then the other one, and this is the most concerning side effect of dig toxicity, is arrhythmias. And it can cause just about any type of arrhythmia. So bradycardia, AV block, PVCs are very, very common, ventricular tachycardia, fibrillation, AFib, all that type of stuff can be a result of that medication. All right, so that's going to conclude our quick review number 3. It's now going to be time for our end of session quiz. So I want you to stop the video. I want you to answer all the questions in the end of session quiz and then restart the video and we'll go over the answers together. All right, we're back and it's time for our end of session quiz. Let's get going. Match the drug or drug class to its mechanism of action or major effect. So the first one we have here are the ACE inhibitors, and they block the enzyme that cleaves angiotensin 1 to angiotensin 2. ARBs, or the angiotensin receptor blockers, will block angiotensin type 2 receptors. Beta blocker, they will counteract the compensatory sympathetic stimulation. Diuretics relieve volume overload. Direct vasodilators will lead to increased venous capacitance and reduce cardiac preload. Digitalis will inhibit the sodium-potassium ATPase pump, reduces the ability of sodium and calcium exchanger to move calcium out of the cell, so you increase cardiac contractility. Phosphodiesterase inhibitors increases intracellular CAMP, increases intracellular calcium, and increases cardiac contractility. And then spironolactone antagonizes aldosterone. Next question. Match the following clinical descriptions with the most appropriate therapeutic agent. And we only give you 4 choices though, so you have to fit these 4 choices in: metoprolol, spironolactone, digitalis, and losartan. So an 85-year-old woman newly diagnosed with CHF who got a cough from her ACE inhibitor. So we talked about this before. If you get a cough with an ACE, you pretty naturally will want to go to an ARB, and the example of an ARB that we have here is losartan. A 71-year-old man with advanced CHF, significant peripheral edema, and myocardial hypertrophy, already on a diuretic, ARB, and beta blocker. Well, sounds like we're still fluid overloaded in this patient, so let's add another diuretic. Which one do we have in our list here? Spironolactone. A 64-year-old woman with atrial fibrillation and CHF. So we have 2 problems that could potentially be treated with digitalis. Next, a 59-year-old man with stable CHF and hypertension, already on an ACE inhibitor and diuretic. Well, questionable, but the next one in line here, which is what we're getting to, would be metoprolol. So use that beta blocker, usually third line in this situation. Next question. Which heart failure drug can cause hyperkalemia, gynecomastia, and menstrual irregularity? So easy one, spironolactone, that aldosterone inhibitor can lead to these androgenic problems. Next question. Which drug for CHF should never be given in an episode of acute CHF exacerbation? So this is a great question because often you'll have patients who have CHF and maybe they're already on this medication and then there's sort of the debate of, well, do you stop it or do you not stop it? And it kind of depends on each situation. But the answer is beta blockers. So if you have someone who's acutely into CHF or newly diagnosed, you don't want to just throw a beta blocker right on top of them all at once because it will decrease contractility and maybe make their CHF worse. So beta blockers, got to be careful. Next question. Classify the following drugs as vasodilators of primary arteries, veins, or both. So we talked about this before. Sodium nitroprusside is going to go after veins. Niziretide will go after both, and hydralazine will go after arteries. Next question. Which beta blocker used for CHF also antagonizes alpha-1 receptors? So remember the one that's FDA approved, but it's not metoprolol because metoprolol only works on beta receptors. Carvedilol. So carvedilol will work on the alpha-1. And what did alpha-1 do? Well, it helps with vasoconstriction in the periphery. So by blocking that, you decrease your peripheral resistance. Next question. Do diuretics reduce cardiac preload or afterload? Well, trick question, they do both. So they reduce preload by reducing venous return, so you're decreasing your overall fluid load. And they also reduce afterload by reducing the arterial blood pressure. So by decreasing the overall volume, you hit both problems. Next question. How should digitalis overdose be managed? So we haven't talked about this yet. This can be a little bit tricky. So remember the symptoms that they had. They're going to have electrolyte problems. So you always want to look at potassium levels. Make sure they're not getting hyperkalemic. And then you have to treat that as needed. You can get arrhythmias. So you're always going to want to check serial EKGs. You want to look for any serious problems there. You want to first check your digitalis level. I mean, that's one nice thing that we can do with digitalis is that you don't have to guess if it's high. You just check the level and you go, whoa, that's high. So you can either stop the dosage or if you get into emergencies, if you get to the point where digitalis is causing major problems, then what can you use? Well, you use the digoxin immune antibodies. So the fragmented antibodies is what you use, but we don't use them very often. I've never seen them used either because they're very expensive. And most of the time you can control digitalis overdose with supportive measures. And then, of course, always, I should have mentioned this in the very beginning, ABC. So always look at your airway, your breathing, and your circulation in all situations of any critical patient. All right, next question. Match the drug with its category. So lisinopril is going to be your angiotensin-converting enzyme inhibitor, or ACE inhibitor. Metoprolol is a beta blocker. Losartan is an angiotensin receptor blocker. Spironolactone is our aldosterone receptor blocker. Furosemide is a loop diuretic. And isosorbide dinitrate is a direct vasodilator. All right, so that's going to conclude our end of session quiz. Hope you learned a little something. Good luck studying, and that's the end of our lecture today.